Hello, NephU community, and welcome to today's episode of Hot Topics in Nephrology podcast. My name is Molly Jansen, and I'm a senior medical science liaison in nephrology with OTSCA. I'll be moderating today's discussion. It is my pleasure to introduce Dr. Thomas Weimbs. Dr. Weimbs is President and Chief Scientific Officer of Santa Barbara Nutrients and professor at the University of California, Santa Barbara. There, he leads a research lab focused on polycystic kidney disease, or PKD. After earning his PhD from the University of Cologne and conducting postdoctoral research at UCSF, Dr. Weimbs started his independent lab at the Cleveland Clinic in 1999, where he began studying PKD with support from a local family affected by this disease. His lab has since contributed significant insights into PKD and developed new therapeutic approaches, including dietary interventions that slow disease progression. His work is supported by federal agencies, private foundations, and biotech companies. In his spare time, Dr. Weimbs plays saxophone in a jazz band. Dr. Weimbs, thank you so much for joining us today.
My pleasure. It's great to be with you, Molly.
So today we're going to discuss the role of the ketogenic diet in managing ADPKD, including its potential benefits, some common misconceptions, and also how your research is bridging the gap between the lab and the clinical practice. We're also going to explain how healthcare providers can better support their patients with dietary interventions, and also at the end talk a little bit about what some ongoing studies aim to uncover about long-term outcomes. So, Dr. Weimbs, to start, could you explain what the ketogenic diet is and what ketosis means? And then I know as we've talked, it's sometimes a misconceptions about what ketosis is and how it differs from ketoacidosis. So maybe you could touch on that as well.
So ketosis, people might remember this from Physiology 101, is a physiological process, a normal beneficial physiological process that allows us humans and other animals to, survive longer periods of fasting and tap into our fat reserves. So essentially, that's the only way we can actually use our fat reserves, by being in ketosis. So it's a completely normal thing, and that's why we have fat reserves. In ketosis, usually we are restricted, carbohydrate restricted, and our body the body metabolism switches over to using fat reserves for energy. And part of the fatty acids are converted by the liver into ketones, and the main ketone is called beta-hydroxybutyrate, or BHB. So if I say BHB, that's what I mean. And the BHB then becomes the main energy source for all the cells and tissues in the body, including the brain, for example. So if we're not eating carbs, nothing bad actually happens. It just means we're using our fat reserves the way we're supposed to. And that's in contrast to ketoacidosis, which is completely different. It's almost the opposite. Ketoacidosis is not a physiological process, but a pathological one. And it primarily applies to people with type 1 diabetes that are completely lacking insulin. So while ketosis is the presence of moderate levels of ketone at very low blood sugar levels, ketoacidosis is just the opposite. You have very high levels of ketones and extremely high levels of blood sugar. So those two conditions are not really related to each other. The only thing they have in common is it's a rhyme, if you will. And that's maybe the reason why, unfortunately, they're always confused and people are very scared when they hear ketosis and they're thinking ketoacidosis. So hopefully that clears it up. And what is a ketogenic diet? So you can, of course, be in ketosis by fasting, but you cannot fast forever, obviously. So there's a trick around it, which is a very low carbohydrate ketogenic diet, where you can restrict the carbs without restricting the food. So you keep eating, the patient keeps eating just normally. You get all your nutrients and calories in, and you can do this essentially forever. So it's a very low carbohydrate diet, usually moderate protein, and you have to make up the difference by fat intake. So that's what a ketogenic diet is. It's been around literally for a couple hundred years at least. It was very early on the only treatment for diabetes. Long before insulin was discovered and made available. It has also been used for about 100 years to treat epilepsy. It's actually very effective there, probably much more effective than many drug interventions. And so to this day, I would say the ketogenic diet, to my mind, should be the number one choice for anyone with epilepsy because it's just much more effective than pharmacotherapy. Yeah, so it's been around a long, long time, has been extremely well studied. It's probably the one diet where there are the most clinical trials, published studies out there.
Thanks, Dr. Weimbs, for providing that overview of a ketogenic diet, as well as helping us to understand the difference between ketosis and ketoacidosis. So, switching gears a little bit, I want to talk a little bit about looking at human evolution. So, you mentioned that, the ketogenic diet has been a treatment that's been around, long before modern medications like, using insulin. Do you think that our ancestors had kidney disease, and could their dietary habits offer any insights into managing PKD today?
Great question. Yes. Currently, something like 14% of the US population have chronic kidney disease. It's just an insane number. It has become the number one non-communicable disease, ahead of cancer, ahead of cardiovascular disease, ahead of type 2 diabetes even itself. So it's a huge problem. Back then, when we evolved as hunter-gatherers, and that's not 100 years ago, that's hundreds of thousands or millions of years ago. Our genes evolved to make our body optimal for the hunter-gatherer lifestyle and diet and nutrition back in the day. And we still have the exact same genes. So you and I, we are actually born as hunter-gatherers, if you will, but we rarely hunt or gather anymore. And we go to the grocery store. So hunter-gatherers would have been in ketosis maybe, let's say, half their life. And that has to do with their lifestyle. They didn't have food 4 times, 5 times, 6 times a day. They had it maybe once every day, once every couple of days. And they ate completely different things. They didn't eat the high carbohydrate diets that we eat today, with lots of grains and potatoes and bread and this and that. None of this was available and none of this had been invented yet. They were eating essentially what they could hunt. Lots of meat, lots of animal foods. Every once in a while a tuber here or there. If they couldn't hunt. A normal lifestyle for Homo sapiens, our species, is to be in and out of ketosis. And that doesn't happen anymore in today's industrialized societies, because we start eating our cereal breakfast, we have lunch, we have dinner, we have many snacks in between, and it never stops. So we're essentially actively suppressing ketosis 24/7. Which is, you could argue, a very unnatural physiological state for us. And so consequently, I would say we have 14% chronic kidney disease in the US. And back in our evolutionary times, the rate of chronic kidney disease would have been essentially zero. So we have gone from zero chronic kidney disease to 14% in a fairly short amount of time. Even a couple of 100 years ago, there would have been essentially no chronic kidney disease. Would have been extremely rare.
Yeah, definitely. That's interesting to hear about the evolutionary aspect. I hadn't considered that, but definitely when you put it that way, it makes sense. I think a nice follow-up to that is talking about your recent paper. So you have the recent trigger warning paper, where you discuss potential dietary triggers for PKD progression. Could you mind discussing a little bit how the ketogenic diet fits into this framework, or anything from that you want to highlight?
Yeah, absolutely. So basically, the most common form of chronic kidney disease today is, due to type 2 diabetes and, poor metabolic health. So we already know what triggers chronic kidney disease en masse, if you will. It's hyperglycemia, hyperinsulinemia, also causing hypertension and, chronic inflammation. So you have sort of like a whole cascade impacting the kidneys directly, causing chronic kidney disease. And in addition to that, you can cause chronic kidney disease, of course, with many other forms of triggers, that can cause renal injury, acute kidney injury, even subclinical acute kidney injury that can be persistent. And there are many factors, things even like uric acid due to high fructose intake, for example, which is the main cause of high uric acid levels. That's something we have studied in the lab, how uric acid microcrystals can damage the kidneys and cause chronic kidney disease in that way. And interestingly, even though polycystic kidney disease, is always thought of as a purely gene-driven disease. The patient has a genetic mutation. It is assumed that's the sole driver of the disease. And we don't think that is actually true. We think it predisposes the patient to become very sensitive to triggers that can impact the kidney. Patients with PKD, the kidneys essentially are overreacting to these forms of injury. And we can study this, of course, in the lab. And some of the studies we haven't even published yet. So some very interesting results where we can essentially mimic the genetics of human ADPKD exactly in rats. And those rats do not form cystic kidneys unless we trigger them with something like a Western diet. We mimic the Western diet and lifestyle, and then they become polycystic. So we think this translates to humans as well. In a sense, you can have a disease-modifying effect by removing these triggers that can impact the kidney. That includes things like poor metabolic health, first and foremost, but also things such as calcium oxalate, microcrystals, calcium phosphate, uric acid, and so on. All the things that impact kidneys, kind of on a daily basis.
Thank you. That's very interesting. I think a nice transition then, because you touched on a little bit of the research you do in your lab. So could you elaborate a little bit more on your research on the ketogenic diet for PKD and also how it translates from bench to bedside?
Yeah, absolutely. So we published our initial studies a few years back, and that has sparked a lot of activity, both in my lab, of course, and in many other labs, and also in clinical studies. So we, and we can, talk about some of the clinical studies as well. But we've also translated the findings into the clinic, into clinical practice by launching a company, a startup company out of the university. It's a benefit company, benefit corporation that has created a medical food containing the exogenous ketone beta hydroxybutyrate or BHB. And that's actually in combination with citrate. And the purpose of the citrate is to antagonize the microcrystal formation that I talked about, and that we also identified as a trigger for accelerating PKD progression. So that's already on the market. And in addition, we have created a ketogenic diet program that patients can sign up for. Doctors can refer their patients into it. It's a completely remote program, so it can be anyone anywhere in the world can use it. It's highly scalable. And it's a 3-month program, so it's quite a bit of a commitment to do it. But patients really learn the ins and outs of how to get into, safely into ketosis with kidney safety in mind, how to implement this medical food. And we've seen just like really good success there. So it's all up and running. So yeah, that's our sort of contribution to translating things into practice.
That's wonderful. It's really cool to hear about the translation from the research lab into clinical practice. And along similar lines, I know I've seen, some studies focused on the ketogenic diet. So I've seen the Reset PKD and the Keto 80 PKD clinical trials. Could you talk a little bit about those and maybe what they've revealed about, the ketogenic diet and the potential for incorporating this into clinical practice as a treatment for PKD?
Yeah, absolutely. So the Keto 80 PKD trial is probably the most important one. That's a trial that was done at the University of Cologne in Germany and published around about a year ago. And this was actually the first randomized controlled trial, the gold standard of clinical trials. It was all done by Dr. Roman Müller at the University of Cologne. And his team, we contributed, by helping with the study design, based on our animal studies and finding some funding for it and so on. And the results were actually surprisingly good, I would say. So it was only meant as a pilot study, relatively short intervention of only 3 months. And patients were randomized into a control arm and a ketogenic diet arm. Everyone, of course, had ADPKD, mild to moderate stage. And surprisingly, in the ketogenic diet arm, there was already a statistically significant increase in renal function based on both creatinine and cystatin C calculated eGFR. That's not something that had really ever been seen in any other clinical trials before, that you could actually improve kidney function, but it matches exactly what we see in our animal experiments, where we can also, and of course in animals, you can document things, much more clearly. You can look at cyst growth, and we had actually already published that we see a partial reversal of disease progression, reversing cyst growth, reversing fibrosis, and so on. The clinical trial kind of mirrored that as results, and also saw a decrease in total kidney volume, which is a surrogate marker for disease progression in ADPKD. So it was, of course, only a relatively short-term trial, 3 months. So we're very interested in seeing longer-term outcomes now.
Absolutely. Thank you so much for recapping that. Definitely important when you can see those significant effects in clinical trials, even though it was, like you said, relatively short, maybe a smaller population. And we'll discuss a little bit later some planned ongoing trials. Getting back to the PKD diet and maybe some of those common misconceptions, we touched a little bit on the difference between ketosis and ketoacidosis. Are there other prevalent misconceptions that you hear about the ketogenic diet? And, could you address some of those?
Oh yes, absolutely. It's very commonly misunderstood. For example, people oftentimes think a keto diet, oh, it's a high protein diet, and that there are many versions out there. It can be higher protein, but sort of the medically used ketogenic diets are usually moderate in protein. And also, if you take in too much protein, it gets converted to glucose anyway, and it defeats the purpose, and you push the patient out of ketosis anyway. So a typical medical ketogenic diet is actually just a moderate protein diet. So that's one misconception. Another misconception, and I don't understand where it comes from. People think that ketones harm kidneys. There's just absolutely zero data on that, zero evidence, and if it's actually just the opposite. And it's something we study also mechanistically in my lab, where we find really ketones, especially beta hydroxybutyrate, to be highly renoprotective, and we think it has to do primarily also with the anti-inflammatory properties of beta hydroxybutyrate. So it acts on certain inflammatory pathways and turns those off, which is always a good thing when we are talking about chronic kidney disease. So these are some of the misconceptions where people maybe don't have quite the right information and have more of a gut instinct reaction there.
Absolutely. And as with everything, there's a lot of conflicting information out there. So it's helpful for you to clear some of that up about protein levels, ketones, the difference between the ketosis and ketoacidosis. So I appreciate that. I think the practical next question then is geared towards healthcare providers and how healthcare providers can better be educated on the ketogenic diet. And then you touched on it a little bit, but maybe what they can do if a patient comes to them asking about the ketogenic diet, where they can send patients for support, maybe where they can access resources, just that type of advice for providers.
Right. Yeah. It's still tricky to answer that because there's not a lot of resources out there. I think that especially nephrologists can tap into. Oftentimes, it's everyone for themselves, trying to learn as much as they can. Medical textbooks are essentially 20 plus years out of date and often really don't help at all. Maybe the best way is, anyone is always welcome to reach out to me, and I can put them in touch with our dietary program, for example. They can refer patients to. I'm always happy to answer questions. And there's a good number of dietitians and nephrologists that are very experienced in this space, but they're hard to find sometimes. So I'm very happy to give people names, if they ask me. Oftentimes, ketogenic diets are used for completely different indications, for epilepsy, for example, even for cancer therapy. So there may be some local expertise around, maybe not in the kidney space, but the approach is very similar anyway. There's still a lot to be done, to educate people in how to actually do this. Oftentimes, patients are just doing it on their own. They're finding resources on their own, on the internets, and so on, which can be good or bad, depending on what they find. And same thing, I'm happy to steer even patients in the right direction. For example, through my UCSB lab, we have a very large Facebook group with over 4,000 people with PKD in there. There's very lively discussions. People share their experiences, what worked for them, what didn't work. So happy to send out links to that as well.
That's great. Sounds like you've really cultivated this nice community of around ketogenic diet with PKD. So generous of you to make yourself a resource as well. So I think to wrap up, maybe we can touch on any of the ongoing or upcoming clinical trials that are planned, or even some ongoing research in your lab that you want to talk about, and maybe some of the outcomes that researchers are hoping to see.
Yeah, for sure. In my academic lab, at the University of California, Santa Barbara, we're really focusing on mechanistic studies, trying to understand what does beta-hydroxybutyrate really do in the kidneys. And there's a lot of really exciting research coming out. We're also studying things like polycystic liver disease. Those are all preclinical, animal model type of experiments. So a lot more papers in the pipeline coming out. And through our startup company, we're doing a lot of clinical research. So we're collaborating with many academic nephrologists, primarily on doing clinical studies. One trial is already in full swing, the largest one actually, that's tests the long-term outcomes of our the medical food product in conjunction with the diet and lifestyle changes. That's at Juntendo University in Tokyo in Japan, with Professor Hori there, who's leading the study, with an enrollment goal of 200 patients, 100 in the control group, 100 in the intervention group, 1-year follow-up study. So that's already in full swing, still recruiting more patients. And it will take a couple of years, until it's all done and the data are out and published and so on. We might do an interim analysis to look at, at like earlier data. So that might come out sooner. In addition, we have several other studies in planning phases. Some of them still require funding, and they're coming up on different aspects. For example, we're very, very interested in looking at ketogenic metabolic therapy in later stage patients. Patients of CKD stage 4, maybe even 5. Currently, it's sort of anecdotal, the information we have, where patients have just done it, and a lot of them have really reported good results, where they think they can slow their disease progression to buy themselves enough time to line up a transplant, for example, a preemptive transplant, so they can avoid having to be on dialysis. Yeah, so a lot going on.
Definitely. Sounds like a lot going on both in your research lab as well as in clinical trials. So I think the whole community is really excited to see what's to come in the future of ketogenic diet, and especially how it applies to PKD. Before we wrap up, is there anything else you want to add about, keto diet, about PKD? Anything else? I want to give you one more chance for some final thoughts.
Yeah, just I would say keep an open mind, especially about something that is out there that might seem upside down with regard to how chronic kidney disease is currently being treated. I personally feel, since we have 14% of people in the US have chronic kidney disease, I think clearly what we have been doing hasn't been working. And maybe it is really time to think upside down a little bit and think more in terms of, evolutionary human biology. How did we actually evolve? What is our genetic makeup? Does it match what we're eating all day long? Does it not match? I would argue it doesn't match at all. And that's giving us all these problems that we see, including chronic kidney disease. So keep an open mind, even if one has learned in medical school, the opposite of what I'm just saying. That doesn't mean it's correct. Yeah.
Definitely. Well, Dr. Weimbs, thank you so much for sharing your expertise with us. It's been incredibly informative, and we greatly appreciate you spending your time with us and discussing the ketogenic diet as it applies to PKD.
Thank you, Molly.
To the NephU community, thank you for tuning in. Be sure to check back for future episodes where we'll discuss more hot topics in nephrology. In the meantime, don't forget to explore the wealth of valuable resources, including nutrition and the NephChef, all available on nephu.org. Thank you.